Hi everyone, and welcome to Anaesthesia Coffee Break and Adrenaline Memories. So we got an episode here where we're going to run through an actual exam. So I'm here with Stan, obviously, and also Mason Habel. So Dr. Mason, he's currently an ATY2 anaesthetic registrar. So Mason trained through the Northwest Training Scheme in Victoria and will begin his fellowship, a provisional fellowship, in a month's time. I think at the Royal Women's and then the Children's. And in 2021, the second sitting of the primary exam, Mason was awarded the Renton Prize, and really appreciate you joining us today to recreate the experience of your 12 viva stations back in 2021. Again, hoping other trainees can benefit from, the same way that he benefited from other similar content. So, Stan gave us his prize-winning viva video back in 2008, and we'll also link to that in the description. So, thanks really much. Absolutely. Thank you so much, Mason, for doing this. The way we'll run this is we will do 4 vivas. So essentially, the actual exam is you get a stem, you read for 2 minutes. We won't go through that process. We'll just read out the stem, and if you're watching this on YouTube or listening to the podcast, just pause that for the amount of time that you want. But we'll just crack on with this viva, and it'll go through 2 vivas of 5 minutes, and then we'll swap examiners. And so there's 4 vivas per station. After those 4 vivas, we'll then do a feedback round where we're just kind of getting Mason's thoughts on the exam and what he thought at various times, and any corrections that he made. We'll also try to recreate it as much as possible, like the exam was. And, Mason, you've got some amazing notes here, which even have documentations of the places where you corrected yourself or made errors, or even what the examiners may have said at a certain point. So it was really useful, and we'll try to recreate that as best as possible. Hey, so welcome, Mason.
Thank you very much.
How does it feel? How does it feel coming back and reliving this viva?
Well, I must admit, I had to spend a bit of time reading the notes that I had taken immediately after I sat the viva, because there were several of the stations where I had no longer remembered any of the detail. Now, sort of 3.5 years later, I felt like it was an interesting process to go back and realize how quickly some things disappeared. But actually, there was a reasonable amount of content which was still fairly familiar. And I always knew that I wanted to kind of make this video, because I think Dan, your viva was 2008, and that was the kind of last full recall that I think I saw on your channel when I was preparing.
Yes.
So I thought maybe a slightly more recent refresh of the style of the viva might be useful.
Yes.
And I think perhaps the only caveat might be that I suspect that my viva had less diagram drawing than perhaps the average candidate sitting now would be. And that's because when I sat my viva in 2021, that was kind of peri-COVID lockdowns. And so, in fact, 2 of my 3 stations were done via a webcam with an examiner in another state, and was drawing on a touchscreen. So I think they've made the diagrams fairly simple to facilitate that. But I think there's probably a higher proportion of diagrams required in the average viva these days.
That's right, because you did yours right after COVID, and
you had to go to a warehouse, get a COVID test 2 days before the written exam, and bring your receipt to show that you were COVID negative. It was an interesting.
That would have added an extra layer of stress and logistics as well with the whole process. And I think you did everything online in terms of the diagrams with the iPads, and they were sharing it across like a screen.
Yeah, absolutely.
I mean, so this is a great plug. So if you've benefited from this, maybe there's someone out there who doesn't have problems sharing their viva to do this, with someone else who's won the prize or done well, or is happy to share their viva experience, would be really, really genuinely helpful for all the people out there who is trying to sit the primary exam, especially those not in really big departments that have the experience of previous examiners going through their past exams, and lots of trainees and consultants going through their past exams. Like, this is hopefully to make this whole system as equitable as possible.
I think the caveat to that was, we actually asked permission from ANSCA, and they actually gave a 3-year embargo on the viva. Yeah. So I think you had to be 3 years out before.
Yeah. So
recreate.
After I was notified that I'd won the prize, I sent the chief examiner an email and said, "Listen, I'm interested in making this video, but I think it's well known that examiners will reuse their viva stations often in subsequent years.
Yeah.
And I certainly had 1 or 2 topics that I'd vaguely heard people talk about in the past. And so I figured that Ansgar might not be too delighted if I just suddenly gave out on 12 of their stations. And they essentially just said, yep, if you wait 3 years, then that's fine.
But that's what's interesting is you can't stop someone saying their viva. That's just freedom of speech, really, isn't it? As in, if you're in a department and someone did a viva last year, isn't that what happens normally?
Well, literally, you've already got your letters, so you can't be cancelled as if So let's not say anything too defamatory about the big 5 letters.
Hey, I accept that. Hey, let's go crack on.
Let's get started. So what we'll do is I will read out the door stem, and then after that, we'll basically proceed with the 4 vivas, and then after that, we'll stop. We'll have a chat about it, and then we'll do it another 2 times. Okay. All right, Mason, you ready?
Yep, let's do it.
Okay, so your station 1, your door stem is, how does dexamethasone prevent post-operative nausea and vomiting? Now, when you come in, you should get the standard question. Have you read and understood the question?
Yes, I have.
So how does dexamethasone prevent post-op nausea and vomiting?
So dexamethasone is a corticosteroid which acts on intracellular receptors to produce gene expression and downstream effects, and is thought to work primarily in the vomiting center.
So when should we give dexamethasone?
Ideally, immediately after induction, as its peak effects reach after around about 2 hours.
And why is it so slow to act?
Due to its intracellular action, it requires DNA transcription and then protein synthesis before the downstream effects are seen.
Now, what is the vomiting center and where is it?
So this is a physiologically defined region that doesn't have distinct anatomical boundaries, but it's thought to be predominantly within the pons and the medulla.
How effective is dexamethasone?
It produces approximately a 20% reduction in the incidence of post-op nausea and vomiting.
And if you compare it versus ondansetron?
Pretty similar, around about a 20% decrease.
And what's ondansetron's mechanism of action?
Ondansetron is a 5-HT3 serotonin receptor antagonist and acts on vagal gastrointestinal afferents as well as in the chemoreceptor zone.
And what are its side effects?
Flushing, headache, bradycardia. That's all for now.
And we also use droperidol. What's its mechanism?
So droperidol is a butyrophenone dopamine D2 antagonist, but it also has some alpha-1 antagonism actions.
And where are the dopamine receptors?
These are also in the chemoreceptor zone.
And side effects of droperidol?
So hypertension, out of calm, inner turmoil, drowsiness, and it has the black box warning for long QT syndrome.
Any other CNS effects?
Yes, it can cause extrapyramidal side effects such as restlessness and tremor.
Now, we also use antihistamines. Where do they act?
So they act predominantly in the vestibular system. However, they often have multiple other mechanisms.
Such as?
Such as 5-HT3, D2, muscarinic acetylcholine, and alpha-1 antagonism.
And where are these receptors located?
So the 5-HT3 and the D2, as I've mentioned, and the muscarinic acetylcholine receptors are in the vestibular system.
And what other drugs do you know which have antiemetic action?
So GABA agonists such as propofol and benzodiazepines.
And how effective are these?
So propofol Tiva reduces incidence by about 15%, and I think benzodiazepines are slightly less effective.
Now, any other agents that you know of?
So cannabinoids and neurokinin-1 antagonists.
And what NK1 antagonists do you know about?
There's oral aprepitant or IV fosaprepitant.
And other than aprepitant, any other mechanism of actions that you know?
So other than the NK1 blockade, I think there's also some cross-reaction with serotonin receptors, and it might cause their downregulation.
And how do NK1 antagonism work?
So they block substance P from acting as the neurokinin-1 receptors.
Fantastic. All right, well, let's move on. Now, what is plasma?
So located within the intravascular space, it's a component of blood with the exclusion of all cellular elements such as red cells, white cells, and platelets.
And what does plasma contain?
It contains fluids, electrolyte, and a range of plasma proteins, including coagulation factors.
And can you classify plasma proteins?
So there's albumin, there are globulins such as immunoglobulins, there are glycoproteins like alpha-1 acid-glycoprotein, and there are complement proteins.
And is albumin a big molecule?
It is large, but I can't tell you how many daltons it is.
Now, where is albumin produced?
It's produced in the liver.
And what are the functions of albumin?
It has roles in acid-base balance, forming oncotic pressure, as well as drug and hormone binding, such as thyroxine.
And what sort of hormones bind to albumin?
So I should have said hormone and electrolytes, such as calcium, and it's typically lipid-soluble hormone.
Such as?
So thyroxine, cortisol, and aldosterone.
Now, what's its role in acid base?
So albumin is a weak acid, but it exists predominantly as a negatively charged conjugate base, and so it is capable of buffering H+ ion.
What is oncotic pressure?
So osmotic pressure is the hydrostatic pressure that's required to prevent the movement of fluid from an area of high solute concentration to an area, from an area of low solute concentration to an area of higher solute concentration. And oncotic pressure is where the solutes in question are kind of large protein molecules which go across capillaries.
Now, how does albumin's negative charge affect oncotic pressure?
So the negative charge attracts cations and limits their crossing of capillary membranes as well.
And what does this effectively do to oncotic pressure?
Doubles it, yes.
And what do we call this?
It's the Gibbs-Donovan effect.
Now, what determines the movement of fluid across a capillary?
So these are determined by Starling's equation. So net filtration is equal to, it's due to a filtration coefficient, which is basically hydraulic permeability and surface area. It's due to the hydrostatic pressure in both the capillary and the tissues, the oncotic pressure in the capillary and the tissues, as well as the reflection coefficient of the capillary membrane.
And what is normal capillary interstitial pressure?
It's about 10 millimeters of mercury.
And how about the net filtration at the capillaries?
So fluid is
filtration.
So fluid is lost at the arterial end, and fluid is returned to the venous end. But overall, there's a slight excess into the interstitium that's around 4 litres a day returned by lymphatics.
Now, what is unique about the glomerular capillary?
It has a really high hydrostatic capillary pressure due to it being a portal circulation, and the glomerulus is between two separate arterioles.
And what about the endothelial barrier?
The barrier has a podocyte basement membrane in addition to the capillary endothelium.
Now, anything special about the capillary endothelium?
I think it has a large number of fenestrations.
Okay, excellent. Now I'm going to pass over to Lahiru.
What is meant by the term FRC?
So FRC is the resting volume of the lung at the end of passive expiration, I should say functional residual capacity. It's where there's a balance between the inward elastic forces of the lung and the outward elastic recoil of the chest wall, and it's comprised of residual volume and expiratory reserve volume.
So what is my FRC if I'm a 70 kilo person upright?
And how old are you?
Let's say 40 years old.
Okay. So it'd be about 40 mils per kilo, and it's about 2,900 mils.
So let's say I'm 50 years old, and plot my FRC on this graph.
Sure. So it would be around about here.
Mm-hmm. What if I lied down?
Then it would be about 2,100 mils, so about here.
And why is that?
So this is due to upward displacement of the diaphragm by the gastrointestinal tract and abdominal fat.
What about if you gave me a general anesthetic?
So there's about a 20% reduction, so maybe about 1,800 mils.
Mm-hmm. And why is this?
So this is due to loss of diaphragmatic tone as well as postural changes in the thoracic spine muscles.
What about if I added a muscle relaxant?
So there's no additional decrease.
Why not?
I presume that's because the maximum kind of degree of muscle tone loss has already occurred.
Mm-hmm. How quickly does this occur after induction?
Rapidly, within minutes.
How long does it take to recover post-op?
Multiple hours.
Okay. What about if I was 140 kilos in weight?
So if you're 140 kilos, the 40 mils per kilo would no longer be a reliable calculation. So it may increase slightly, maybe about here.
Increase?
I guess you're probably not a 140 kilo rugby player where it might increase. So if it was due to obesity, it would actually decrease from extra-abdominal compression. So maybe about here.
Okay, sure. So does FRC increase with age?
Yes, it does, but only slightly. And this is due to loss of elastic tissue, also called senile emphysema.
What is closing capacity?
This is the volume of gas in the lung at which small airway closure begins to occur.
And where does the small airway closure occur?
It goes in the bases or upright or posteriorly in supine.
And why does it occur in the dependent regions?
These areas have smaller resting alveolar volume and so less elastic traction on the small airways.
Does closing capacity increase with age?
It does.
Can you draw the effects of this?
Sure. So I guess here we'd have FRC while you're upright, increasing slightly with age, and FRC while supine. And the intercepts are roughly at about 44 to 66 years old. So it would look something like that.
Why are these intersections significant?
So there's a chance that you get small airway closure during tidal breathing. And so this would occur at 44 while supine or at 66 years old while upright.
And why is this important?
So this can result in shunts and arterial hypoxemia.
Does closing capacity change with anesthesia?
I don't believe so.
What are the other consequences of a decreased FRC?
So there's a reduction in compliance, an increase in work of breathing, there's an increase in airway resistance, and an increase in pulmonary vascular resistance.
How does the increase in pulmonary vascular resistance occur?
So pulmonary vascular resistance is minimal at FRC, and at lower volumes, there's a reduction in elastic traction on extra-alveolar vessels.
Okay, good. We're going to move on to another topic now.
Mm-hmm.
Please write out a list of the contents in a 20 ml ampule of propofol.
So there's 1% propofol, there is 10% soybean oil, there is 2.25% glycerol, there's 1.2% egg yolk lecithin, and there's sodium hydroxide, and some brands include antimicrobials like EDTA.
Anything else? It's a big component.
Water.
What other additives are present other than EDTA around the world?
Sodium metatasulfite is used.
How effective is EDTA?
I think it's quite effective.
Mm-hmm. If I leave propofol drawn up on the table, how long can I leave it?
You can leave it for 12 hours, but I'm unsure if Diprivan has different recommendations given it has EDTA.
How long can I leave it if it's in a syringe driver?
This is 24 hours.
Mm-hmm. Why do we add glycerol?
This makes propofol isotonic.
And why is this important?
Decreases the pain on injection and also prevents red blood cell lysis.
And so why do we add sodium hydroxide?
This is to alkalinize propofol.
What is the normal pH of propofol?
It's roughly sort of 6 to 8, depending on the brand.
And why do we add egg lecithin?
This is an emulsifier.
And how does it work?
It stabilizes droplets and prevents their coalescence.
How does it do this?
I think it creates a negative charge around the droplets.
Okay, what is an emulsion?
An emulsion is a two-phase system of immiscible liquids where one is dispersed as fine droplets within the other.
And why is propofol white?
I think this has to do with the size of the lipid droplets causing refraction of light.
Could we make it clear?
I think you can by changing droplet size. I'm not sure in which direction. I imagine making it smaller.
What are the side effects associated with each component?
So I guess starting at the top with propofol, there's propofol infusion syndrome.
What is propofol infusion syndrome?
So this is an impairment of the electron transport chain, resulting in lactic acidosis, rhabdomyolysis, and renal failure.
Who gets this?
It's in kids, in those with mitochondrial disorders, and those on high dose and long duration infusions.
And what are the dose limits?
Around 200 milligrams per hour.
How do you know a per kilo limit?
I think it's around about 3 milligrams per kilo, with 200 as a hard max.
What are the other side effects?
So there can be allergy to EDTA.
Can you give propofol to people with egg allergy?
Yes, because most people's egg allergy is to egg white, not the egg yolk.
Any others?
You can get rare soy allergy.
And what causes pain on injection?
It's not clearly understood. Some think it's related to the soybean oil. Others think it's related to the propofol itself, stimulating TRPV receptors.
How can we decrease pain on injection?
You can do a slow injection. You can use a large proximal vein, or you can use lignocaine.
When would we want to mix lignocaine with propofol?
Immediately prior to administration.
How much lignocaine can we add to propofol?
I think the manufacturer says none because of concern of destabilizing the emulsion.
Yeah, but how much am I allowed to add?
I'm not sure.
That's time. Excellent. Hey, well done, Mason. That's epic.
Station number 1 finished.
Station number 1 finished. Wow. Whew. I imagine this was pretty similar on the day, but the way you're answering it, obviously it's quite fast. It's to the point. You're not really mincing any words. You're answering the question absolutely directly without wasting any time. Is that how it was on the day as well?
I suspect for some, I think particularly like the first time to hear about antiemetics, the vast majority of my answers were like 1 or 2 words. The questions were really short and simple. Yes. And so I think I didn't feel a need to rephrase the question back at the examiner. I could just say, what's on downstream mechanism of action? 5-HT3 receptor antagonist.
Yeah.
And in fact, I felt like I was getting interrupted a lot and prompted a lot to almost flesh out my answer, which is always a hard balance with the vivas is, do I give just exactly the question they've asked me for, or do I try and give a little bit more breadth? And sometimes that might waste your time, and sometimes it might avoid you getting asked a subsequent question down the line, and it's really hard to know that balance. And so I really felt like I was having my teeth pulled in the first one. So, all right, you've said this receptor, but where is it located? Next drug, this receptor. Okay, where's that receptor located? All right, this drug, where's that receptor located? I felt like I just wanted them to say, can you just draw the diagram for me of where all the receptors are? And it might have saved us a lot of time.
But also, this is good, right? Because these are the questions that they're giving you marks for, and they're asking you directly without there's no vaguety to their question. I think that potentially that's a really useful strategy, just to answer the question, short words, and they probe for more if they want to.
Yeah, absolutely. I completely agree. Yeah, I have to. They're not trying to punish you. It's just the style of the exam.
Yep. I think one of the key things that I found from your Viva was that you went through about 20 questions and maybe even more on the day. And I've always said that when you're looking at the prize winners and the merit winners, they can get through a lot of the content and a vast amount of questions and topics. And I think it's also to do with the nature of the efficient way that you answer the questions. And you're looking at, questions that you're answering in like 10 to 20 seconds. So that's sort of a key thing. Now, I think looking back now with those Vivas that you had, can I ask you, did you have them before, like during your lead up to this?
I don't actually think I'd ever had a Viva on antiemetics, but it was an incredibly common short answer question. And so it was something that inevitably studied multiple times. I think the plasma was probably a bit of a curveball. I don't think I'd ever had a Viva on what is plasma, but was specifically about plasma protein. Which it ended up almost being a whole Viva. The first half was about albumin, second half was about, Darling's forces. So I felt like I was pulling that from lots of different areas of study. FRC, I reckon I had about 15 Vivas on FRC, because anyone who hasn't given a Viva in a long time, it's like seems to be their go-to. So I think that was, I found the FRC Viva a bit strange because they put this graph in front of me, and when they asked me to draw, they were literally asking me to draw like one dot each time. And like, I felt like I had a pen in my hand and I needed to be doing more. And they were just like, just draw one dot, just draw one dot.
Yeah.
And so that felt a bit unusual. And I think that's the style with some Viva examiners, is they almost construct the graph with you over time, but they don't necessarily at the very start of the Viva say, just draw me the whole graph on this. Sometimes you don't even realize what you're drawing until halfway through. And so for this one, this was, the FRC and closing capacity graph, but they were kind of constructing it over the course of 5 minutes rather than just saying, draw this for me at the beginning.
Yeah, I imagine if they were to do that, maybe a percentage of people would get it so wrong that they'd have to go through more paper and more time. Maybe strategy for getting people through it a bit better.
Yeah. And I think the Propofol Viva was not one I'd had before. The contents and the side effects was an old FAQ that was floating around. And I think I'd heard a previous colleague of mine who I think had been unsuccessful in the exam the year before had reflected on, they asked me why Propofol's what. And the immediate reaction when you hear that is, oh my God, the Viva's going to be so hard. They're asking all these questions I've never studied. But there's also a good chance that that candidate actually did really well on the Propofol Viva and they might have failed because of something else. And I almost felt like when they asked me why it's white, like I kind of knew because I'd looked it up, but I almost didn't want to be too obvious about it because I'm like, I obviously got this from somebody else. So I think I was almost tactically a bit vague there.
Did you play the game like, look, from first principles, from my knowledge of physics and refraction,
color physics and light? Yeah, exactly right.
Hey, should we go through, Mason, have a look at your Vivas and make comments on any of the stuff that we've already gone through?
Were there any questions, that you thought perhaps were a little bit tricky, or perhaps you could have answered differently?
I think most of the anti-emetic Viva was that was just like,
anti-emetic is pretty straightforward.
Give me 20 different facts. And some were core stuff and some were, I think a big thing for that was when asking for like side effects of different drugs. And certainly when I've given this Viva to people afterwards, if anyone says, give me a list of side effects or give me a list of examples of something, if anyone gives you less than 3, it sounds really awkward. And you need to get at least 3 or 4 to show that you've got some breadth. But at the same point, you don't want to give 10 because you want to move on to the next question. So on death, John's got a whole bunch of extra side effects, but I kind of just got a bit stumped and said only 2 or 3.
I think one of the traps there, perhaps not even a trap, I think some people might approach it as systems-based, but I think, you have to go back and actually think about it. Like you would have to go, these are the cardiac effects. These are the CNS effects. These are the gut effects. But I think most naturally, and certainly what I would do is what you did would just be listing them. But I think...
Yeah, I think that's a really good comment. And I've probably suggested to people that if the DORS question or the first question of a Viva is discuss, the side effects of something, then maybe spending 30 seconds and saying the cardiac, the neuro, the respiratory makes more sense because it's kind of your first foray into the question to put yourself out there. But when it's just like a random question in the middle of it, if you over-classify in the Viva, it has the potential absolutely to slow you down a lot. And I don't think you get any more marks if I had said that, the gastrointestinal side effect of ondansetron is constipation, as opposed to just saying one word, constipation, move on.
Yeah. So, as sort of, I'm not an examiner, but, doing this, there are certain sort of keywords that you use that I think it pushes you above what I would consider sort of a strong pass to that merit prize areas. And I'll sort of show you what I mean, because, when you're answering the anti-emetic question Viva, which is a very straightforward Viva, you were adding things like, with regards to how droperidol works, like butyrophenones, like the way that you said it, very natural, came across and you're going, oh, wow. Okay. Like most candidates would probably say it's a D2 antagonist, whereas you've gone, it's a butyrophenone D2 antagonist. And I think other things, when you're talking about the NK1 antagonists, you were actually able to actually name what they were. And I think that's the level of detail, not required to pass, but I think that differentiates, your Viva to, a standard Viva.
And I think it's certainly, like inevitably there will be areas that you know more about and areas that you know less about. And if you give them a little bit of a hint that this is something I know well, it seems that they're more likely to ask you follow-up questions on that area. And paradoxically, sometimes if you answer it so confidently, they'll say, I don't need to bother asking any more questions about this. They understand it really well.
Yeah.
And I actually had another guy from my study group who got the exact same viva batch as myself, which allowed us to kind of compare what we were asked. And I was quite surprised that we were asked a lot of our questions in really different orders. And some of our vivas were almost completely backwards. And so, for example, when we said side effects, the first thing you said of side effects of propofol was pain on injection, then they started asking you all those questions then. And they said, give me a list. And after you said one thing, they interrupted you and asked another question. It wasn't that the first thing you said was incorrect. It was just that you probably already finished the core question. And now they're just saying, okay, let's try to get a few marks on some other random topic.
With that propofol question, what are the side effects? And you went propofol infusion syndrome, and they cut you off. But it wasn't like you were about to say, if you'd said hypotension or apnea or respiratory depression, did your colleague or your study mate, did they go down another pathway, or was it absolutely about propofol infusion syndrome?
I think they had probably started pain on injection, and it was phrased as what are the side effects of the components. So I think I was, I might have said hypotension, respiratory depression, but I think it was more about, the glycerol and the egg yolk. And I think you kind of got a vibe that that's where it was going, as opposed to being just about drug propofol itself.
Now, the other thing that I note about that viva, I think when you answer the questions with regards to how long you could leave it drawn up, I think you said 12 hours and 24 hours, but then you've had it different.
Yeah, so I looked those up recently, and my answers to both of those were incorrect. And so I think it's the MIMS handbook recommendation for all of the brands that Australia has is 6 hours if it's drawn up on the table, and 12 hours if it's being given in a syringe driver. So when we're doing these cases, we should probably be changing over our propofol line.
But I think that's quite insightful. Is that you don't need to be perfect in this exam to actually do very well. Like, you can be sort of around the ballpark, and you know what, 6 to 12 hours, you'd accept that, and so 12, 24 hours. So there's no, I think, question. I think this highlights it that, if you get it incorrect, they're going to say, nah, you're not going to fail the viva, you're not going to get the prize, you're not going to get the merit, so.
Yeah, and I think that was possibly my experience with doing vivas in the real situation compared to doing practice vivas with non-examiners, is that if I was doing this with somebody, just your local Joe Bloggs consultant in your department, if I said 12 hours, they might have said, are you sure? And that has the potential to derail you. Whereas I found that there were certainly times where I said something incorrect or said I didn't know, and the examiners would then say, well, what do you think about this? But they were much better at kind of steering you in a direction. And often that was because you needed to get this question to move on to the next section of the viva. Whereas if it was this was just a standalone factual point, you got it or you didn't, and it didn't derail your whole viva if you got it incorrect.
Yeah. And it's just not that material for the whole of this viva as well.
Hey, what do you think about the last one where they were pushing you about lignocaine and propofol?
Oh, that's...
I don't really know what that's to do with. I feel like...
Yeah, there was an article.
I feel like I'd maybe heard in a podcast or something that, lignocaine should be drawn up immediately prior to injection, not drawn up and let sit there for a long time because it might mess around with the emulsion. I feel like I've also come across things saying, it should be 20 milligrams of lignocaine in 200 milligrams of propofol. But I don't know if that's just because lots of our departments have little, 2 mil vials of 1% lignocaine. Yeah. So I'm not sure that if you use too much lignocaine, if it messes with it or what.
I should have looked this up before, but yeah, a study came out after my primary exam where they just took different concentrations of lignocaine and put in propofol. I can't remember the value exactly, but if I remember correctly, it's 40 milligrams of lignocaine will cause precipitation of a problem with propofol. But then that's also a function of time as well. Like you draw it up straight away and inject it. That's not going to necessarily.
And I think it would almost be important to note as well that this is a question that I was very okay with not knowing the answer to.
Yeah.
And I felt no obligation. And even when I looked back at my notes in the last week preparing for this this conversation, I didn't look it up because I'm okay that I can sleep tonight not knowing that information.
Not knowing,
And for anyone who's currently studying for the primary, that is not going to be the question that in any way determines whether you pass or fail the viva. So it's not worth stressing over too much. Same with why is propofol white. You know, you can definitely pass the primary exam without knowing why propofol is white.
But if you wanted to know, it's all here. And you are right in terms of saying that with the product information, it will say you can't add anything. But I think it's in Stolting and Miller's that you can add, as you said, 20 milligrams, which is why you won't see it in all places, but you will see it in some anesthetic trolleys. You'll see 2 mils of lignocaine there. And they specifically stock it because of the idea that that's the maximum allowed lignocaine that you can add. So I think the answer that they were looking for was, 20 milligrams, as you sort of said. But I don't think there's any official line with that other than, from those textbooks.
I think the official line is don't mix any drug ever.
Yeah, don't mix any drug ever.
Just mix the acids with the acids and the bases with the bases, and you'll usually be fine.
Yeah. All right. Let's go on to the next one. All right. Okay, so now, just before we move on to station 2, how long was your break between station 1 and station 2?
So mine was slightly different, but I think the standard is that the bell rings, you walk out, another bell rings, and you start reading the question on the wall. And you can't write anything during your 2 minutes reading time because it's just on a wall. You're standing there. You don't have a clipboard, which is very different to the part 2 exam where you can scribble some notes. And in fact, the moment the bell rings, your reading time for the next station has started. So you don't say goodbye. You stand up and you run to the next station.
Yeah.
Ours was actually 4 minutes when I sat because we had 2 minutes of reading time and then 2 minutes of tech support checking.
Right.
Because we had to go in and make sure that the iPad worked for drawing diagrams and that the webcam worked and that our headphones worked. So it was actually quite a lot of time in between.
Yes.
But I think the standard is pretty much the bell rings, you say, see you later.
Yep.
You walk out, another bell rings like 10, 15 seconds later, and then you start your 2 minutes reading time.
Yeah. So, I think now, they just do it all in sequential 1, 2, 3. Because I think when Lara and I did it, ours was, 1 in the morning and then probably 1 later in the day. So,
yeah. And I don't know if the geography setup was always the same. Like for my primary exam, it was like there was a cubicle, just next to the door was the STEM. So you could read the question and you could kind of just see into the room out the corner of your eye.
Yeah.
And then my part 2 was the other way around, where the STEM was on the opposite wall. So you're reading and the examiner's right behind you, staring at the back of your head for 2 minutes.
Yes.
And then you turn around and go in. But I think that's just how maybe they mix it up every year to keep it interesting.
And would you ever look at one of your other peers and go what did you get? What question you go? Or is there just no time?
I think at that point, you just are entirely focused on the big bit of paper in front of you.
Yeah. Okay. All right. Let's get started. So the second station, the door stem is what is saturated vapor pressure. Now, have you read and understood the question?
Yes.
So what is saturated vapor pressure?
This is the pressure of a vapor, which is in equilibrium with its liquid phase.
Now, I'm going to show you a drawing, and if you head to your screen, you can see that drawing there. Yep. Now, if we have this as our vaporizer, what would be the output of sevoflurane?
So it would be 154 millimeters of mercury or 21% Sevo.
And if we cranked up the flows and kept them up, what would the output still be the same?
No, because of the loss of the latent heat of vaporization, this would result in cooling of the volatile and a reduction in saturated vapor pressure.
Now, how do we overcome this?
So we can use things like wicks and baffles to increase the surface area for evaporation.
Now, with sevoflurane, hypothetically, we like to giving around sort of 2 to 4%. How do we go about achieving this?
So we would introduce a bypass chamber with a splitting ratio. So for example, if you wanted to give 2% CO, I'd want 1/10 of the flow going through the vaporization chamber and 9/10 going through the bypass chamber.
Now, on that diagram, can you show me what this looks like?
Sure. So, up the top, we have the bypass chamber, and down the bottom, we have the vaporization chamber, and then there's an adjustable valve at the top.
Now, in this chamber here, can we add another volatile like desflurane?
So desflurane can't be used, and its concern is that its boiling point is close to room temperature, and so this might risk a variable saturated vapor pressure and variable vaporizer output.
All right. Well, how about, let's say we're up in Tassie and the theaters are well below its boiling point, well below 20 degrees. Any other reason why we couldn't use it?
Not sure.
Well, how about if you think about its saturated vapor pressure? How might this affect it?
So desflurane saturated vapor pressure is really high. So I guess you'd need a lot of bypass flow and very little vaporizer chamber flow to produce your output. So I guess any small errors could produce like significant changes in output concentration.
Yeah. Now, you mentioned the change in temperature before. How do we overcome this?
So first, there's temperature stabilization with the use of heat sinks with a high specific heat capacity and a high thermal conductivity, as well as temperature compensation, which is where there are temperature-sensitive valves made from things like a bimetallic strip, ether-filled bellows, or electronic method.
And how do these temperature-sensitive valves work? If you can sort of show me on the diagram as well.
Yeah, so they adjust this sort of valve at the top. They adjust the splitting ratio to maintain a constant output, so redirecting flow through the vaporizer or bypass chambers.
Now, what is the pumping effect?
So this is where high downstream pressure can cause retrograde flow back through the vaporizing chamber. And the concern is that this high concentration gas can end up in the common inlet and then subsequently go forwards through the bypass chamber.
Now, is it possible to put another volatile like isoflurane into this vaporizer?
So this is prevented with things like color coding, keyed ports, and electronic gas analysis.
Okay, but hypothetically, let's say I was able to get isoflurane in there, what would happen?
So ISO has a saturated vapor pressure of about 240, which is more than sevoflurane. So it would have a higher output to what we dialed. So if we dialed 2% SIVO, we'd probably get about 3% ISO. But there would actually be about 3 Mac of isoflurane compared to 1 Mac of SIVO.
Okay, now let's move on. How is blood glucose regulated?
It's regulated by several key hormones, namely insulin and glucagon, as well as adrenaline, growth hormone, and cortisol to lesser effects. And
what are the effects of insulin?
Insulin has anabolic and anti-catabolic effects. In the liver, it results in increased uptake and conversion of glucose to glucose 6-phosphate, as well as glycogenesis. Muscle also has uptake and glycogenesis. There's de novo lipogenesis in fat, as well as in the liver. And it inhibits gluconeogenesis and ketogenesis.
And what would be the ratio of insulin and glucagon after a 48-hour fast?
After 48 hours, it would be about 1 to 2.
How about normally? Without fasting, what would that be?
I'm not sure.
That's okay. Now, what would be the effects? What would be the effects of having this 48-hour fast?
So at 48 hours, glycogenolysis is likely to be mostly complete, and gluconeogenesis would be increasingly taking place.
And you mentioned that catecholamines before. What would you expect their levels to be after a 48-hour fast?
They would be increased.
And would you expect a patient to be hypoglycemic?
In healthy individuals, I would expect a blood sugar range fairly normal due to the above-mentioned mechanisms.
And what is gluconeogenesis?
So this is the generation of glucose from non-carbohydrate precursors, things such as glycerol, lactate, alanine in the liver, and glutamine in the kidney.
Now, does it continue with even longer starvation?
After a period of time, it decreases to preserve protein levels, and instead there's an increase in lipolysis.
Now, what do fat and muscle use at this time?
So they develop an increased reliance on fatty acids and use less glucose.
And how about ketones after 48 hours? What would you expect that to happen?
In a healthy individual, I probably wouldn't expect ketone formation until sort of days 4+ of starvation.
Okay. And now, what tissues are obligate glucose users?
The brain as well as red blood cells.
Is the brain able to use other substrates like ketones?
I think the brain can use ketones, but it requires some time to adapt to utilizing it as a substrate.
Now, who is vulnerable to ketoacidosis?
So type 1 diabetics, poorly controlled type 2 diabetics, and those on SGLT2 inhibitors.
So why don't, like healthy patients like you and I, why don't we get ketoacidosis?
It's because we have sufficient oxaloacetate to allow the Krebs cycle function without the version of acetyl-CoA to ketone bodies.
Sure. Is there anything else that would perhaps help that regulate this?
Just having sufficient insulin levels. You're
good. Okay, I'm going to hand over to Lahiru now.
Mason, what is the INR?
So INR is the International Normalized Ratio. It's the ratio of the prothrombin time of the test to the prothrombin time of the reference, raised to the power of the International Sensitivity Index.
Why can't we just use PT?
The INR instead accounts for differences in reagents and testing equipment in different labs.
What reagent is added?
It's tissue factor.
How exactly do they do the test?
So they add tissue factor first, they then add calcium and start a timer, and I think they have a device that slowly rolls the tube and observes to the formation of the clot.
Isn't there calcium in blood already?
There is, but this has been complexed by the citrate in the blue top blood tubes.
Why are we testing? What are we testing with the PT test?
So this is testing the extrinsic as well as common pathways.
Can you describe this?
So tissue factor and factor 7 combine to activate factor 10, and factor 10 then goes on to activate the common pathway.
What might cause an elevated INR?
So warfarin, malnutrition, and liver failure.
How does warfarin work?
Warfarin is a vitamin K epoxide reductase inhibitor, and it reduces the synthesis of factors 2, 7, 9, 10, as well as protein C and F.
What does protein C do?
It inhibits factors 5 and 8.
How does it get activated?
It's supported by protein F.
Anything else?
I don't know.
How could we reverse warfarin?
So you can withhold it and wait. You can give vitamin K, you can use fresh frozen plasma, prothrombin complex concentrate, or Zovastat.
How do we get FFP?
So this requires plasmapheresis from a donor, either at the time of donation or after a whole blood collection.
How is FFP stored?
Stored at 4 degrees Celsius.
Why do we call it frozen?
I retract that. It is stored frozen.
Could we use cryoprecipitate to reverse warfarin?
No, because it has none of the relevant products.
What is in cryo?
So cryo has factor 8, factor 13, as well as fibrinogen and fibronectin.
When would we use cryo?
So most commonly in fibrinogen deficiencies, such as DIC.
Cryo also contains von Willebrand's factor. What does this do?
So this cross-links collagen to glycoprotein 1b9 during platelet activation.
Any other roles?
I can't remember.
Do we need to cross-match FFP?
You do, but just the ABO group, not the rhesus group.
What is the universal FFP donor?
This would be AB positive.
Okay, we're going to move on to another topic. How is oxygen carried in the blood?
So some is dissolved, but the majority is bound to hemoglobin.
How much is bound to hemoglobin?
So there's 19.7 mils per 100 mils of blood.
How did you calculate it?
So this is 1.34, which is toughness constant, multiplied by the hemoglobin concentration, multiplied by oxygen saturation.
How much is dissolved freely?
So this is 0.003 multiplied by the arterial partial pressure of oxygen.
So if we have 20 mils per deciliter in 5,000 mils of blood, do I have 1,000 mils of oxygen?
No, because not all of your blood is arterial.
How much is venous?
About 70 to 80%.
What is hemoglobin?
Hemoglobin is a quaternary polypeptide with 2 alpha and 2 beta chains, each surrounding a heme group in HbA.
What other types of hemoglobin are there?
So there's HbA2, fetal hemoglobin, methemoglobin, carboxyhemoglobin, as well as thalassemias.
What are the other functions of hemoglobin?
So there's carbon dioxide carriage, acid-base buffering, as well as drug metabolism, such as sodium nitric oxide.
Tell me about fetal hemoglobin.
So this contains 2-alpha and 2-gamma chains, and 2,3-DPG is unable to bridge the gamma chain, which results in a left shift of the oxyhemoglobin dissociation curve.
What is the advantage of this?
So the increased oxygen affinity facilitates increased uptake of oxygen from the internal circulation.
Is there a left shift? Is this left shift a problem for offloading oxygen in the neonate?
I don't think so, because of a large fetal polycythemia.
Anything else?
I'm not sure.
What else causes a left shift?
So this can also be caused by alkalosis, hypocapnia, reduced levels of 2,3-DPG, and carbon monoxide.
Why does carbon monoxide cause a left shift?
So carbon monoxide has a very high affinity for hemoglobin, so hemoglobin becomes saturated earlier, even though it's not saturated with oxygen.
How much greater affinity does it have?
So it's about 200 times higher than oxygen.
That's about right. What is the P50 of fetal hemoglobin?
That's 17 millimeters of mercury.
How does 2,3-DPG work?
So in adult hemoglobin, it's linked to the beta chains and stabilizes the 10th conformation of hemoglobin.
What is the curve position in pregnancy?
So there's a left shift of the curve produced by alkalosis and hypocapnia, and there's also a right shift, which is produced by increased levels of 2,3-DPG, and overall it's relatively neutral.
What is the Haldane effect?
So the Haldane effect is an increased CO2 carrying capacity by hemoglobin in venous blood compared with arterial blood as a result of the removal of oxygen.
How is CO2 carried by hemoglobin?
So some is carried as carbaminohemoglobin, but hemoglobin also buffers hydrogen ions, which is liberated from carbon dioxide reacting with water to form bicarbonate and hydrogen. And this is done by the histidine residues.
In what form is CO2 predominantly carried in arterial blood?
Bicarbonate.
How much?
About 90% of the content.
What about venous blood?
Slightly more.
And that's the end of the station. Great.
2/3 done.
That's done. Do you want to go systematically through it, Mason, with any comments?
Yeah, let me just scroll back up to my cheat notes, which I'm definitely not looking at throughout all of this.
Hey, you remembered it from however long ago. That's great.
So saturated vapor pressure and vaporized stuff. I think this was. I don't think this is something that I'd had a Viva on before. But I think most people would consider how vaporized work is pretty core content. So it was something I knew well. I think I mainly use that How Equipment Works website, which I imagine is still floating around for a lot of the electricity study stuff. And I found that really useful, particularly for the pumping effects diagram understanding. And most of the questions were fairly physics-based. I must admit, being asked about using a desflurane vaporizer in Tasmania, I found a bit confusing. And I didn't want to argue that I'm pretty sure the operating theatres in Tasmania are equal to the temperature.
Same temperature, yeah, correct.
In mainland Australia, having also lived in Tasmania for 5 years. But I could kind of, eventually they kind of, so this was like a classic example where I said, I don't know, I'm not sure. And then they kind of steered me to the answer and talking about desflurane saturated vapor pressure.
And it's really interesting because I had actually heard of this Viva before, and as well as the Tasmanian question, but I never got the follow-up question that you had.
Yeah.
So what I was told was that there was a question with regarding desflurane and, using it in Tasmania and how that might affect it. And I didn't understand what it was. But now that I actually read your stem, I get it. Because what they were alluding to, which is what you talked about, was that because of desflurane's very high saturated vapor pressure of 669, it means that you have to use, as you said, very small.
You'd be putting like a trickle of stuff through the vaporizer chamber and just liters and liters flowing.
That's right. And you were absolutely correct in terms of saying that, with regards to any of those changes, like there's just too much margin of error. So that's where it was getting at. And I think it was really, it was actually fantastic that I've got to see your one, because now I understand. Because I think previously when I was running this as a workshop, I was going, yeah, you got to watch out for this Tasmanian question. I've got no idea what the hell they're asking. Like, I don't even know what they mean, but now, yeah, that makes sense.
I mean, it's a bit of a red herring here, because it's irrelevant that it's in Tasmania. All theatres are cold.
And maybe they said, oh, what about if we're using it in Tasmania where it's much colder? And essentially they were saying it's not the boiling point that's the problem. There's something else going on.
Yeah.
Like, well, we're using it in outside in the wild in Tasmania.
And I think that's the challenge of vivas, is that conceptually, as an examiner, you're trying to get across the principle, which is that you want the candidate to ignore the idea of temperature, and you want them to focus on desflurane's high saturated vapor pressure, which is why you can't use it in a sevoflurane vaporizing chamber. But you don't know how to ask it well enough, and you use this scenario, but it just causes more confusion, because like you and all of us are going, well, doesn't matter. Like, theater temperatures around the whole world are probably the same, at about 18, 19, 20 degrees. Like, it doesn't matter. You go off to, in Darwin, they're going to run the theaters lower.
I think it requires you to kind of just be a little bit imaginative with their questions. Like I've done previous vivas with ex-examiners, which was like, if I filled up a bathtub with sevoflurane and you sat in the bathtub, would you get anaesthetized? And so, like, it's obviously completely ridiculous, but
yes,
if you just still apply, it's, I guess, for a lot of these physics kind of things, I imagine it must be challenging to write vivas which ask you to give it an understanding, and not just, I know what the SVP is, I know the definition of it, but to actually demonstrate applying it.
Yeah.
And I must admit, the question about putting isoflurane in a sevoflurane vaporizer, I reckon I'd heard that exact question in an American podcast called ACRAC. And so I knew exactly what would happen. So it probably came out sounding much more impressive than just because I'd memorized the response.
I think you were the first one to actually get the viva, because now, because of that, we've actually had workshops on that and how isoflurane in a sevoflurane vaporizer affects it. So
which is tough, because I don't know if either of you guys have ever anesthetized anyone with ISO. I certainly never have.
Back in the day.
No, we have. Yeah.
Maybe I think you're younger.
Much of a muchness.
It's always intergenerational. Like, I think there's one consultant at this one hospital who really favored halothane, because that's what they did for pediatrics for many years. Like, there's always. I mean, soon it'll be desflurane. People will be going, oh, Mason, hey.
I reckon I've used des about half a dozen times in the course of my training. I think I've given this viva to a handful of people subsequently, and one thing that I often see people, or at least I believe they misunderstand, is when describing the pumping effect. A lot of people often talk about, you get retrograde flow in here, and then you get retrograde flow going back, and so you've got a slight increase. But my understanding, largely from the great diagrams on that How Equipment Works page, was more that you get flow not just through the bypass chamber, but actually into the vaporizing chamber. So anything that comes back up here is now 21% SIVO, as opposed to this is, 4. So if you get 4% back into here, that's not a huge problem. But if you suddenly get 21% coming through the bypass chamber, that has the potential to produce a really massive overdose.
Yeah.
Interesting.
Now, I think there was one thing that I wanted to chat about. Well, I think it was, the question that La had, I think, with the left shift of oxygen for the neonates. Like, I think they were trying to push you on something. Do you know what they were trying to push you towards?
I'm not 100% sure. And conceptually, I understand why they asked the question. The left shift is good for getting oxygen from the mum, which inherently means it must be unhelpful for releasing the oxygen to the neonate itself.
Yes.
And so, I think I talked about the fact that fetal hemoglobin is really high, like 180 or something. And I think that even with fairly low saturation levels, I had some old note that was even with fetal stats at 80%, they still had something like 16 mils of oxygen per 100 mils compared to 20. I'm not sure if they might be referring to the fact that the kind of fetal circulation is slightly more acidotic than the maternal circulation, and that might produce the right shift that neutralizes things. But I'm not sure if there was something else that they were getting on.
Yeah. I mean, naturally, I think you would, as you talked about, with increased affinity for oxygen, there's decreased ability for it to release oxygen to the tissues. And I think, where they were sort of heading to is how does the fetus compensate for that? Perhaps.
Yes.
And I think you sort of had the discussion on that with regards to polycythemia, perhaps increased capillary network. But that all seems to make sense. And even the acidosis, that makes sense too.
And hopefully people like listening have already got a vibe that the number of times I've said, I'm not sure, I don't know, I'm not aware, is like it wrapped up pretty quickly, even when you think you're doing pretty well in a viva, that they're going to just keep asking questions that get weirder and more obtuse until you have to say that you don't know. I think I remember
go on.
Sorry, I was going to say, I think like I often, when I do practice vivas with people who are preparing to sit, a lot of people get very psyched out by saying, I don't know, and not having answers to questions. And I, at some points I had people give me advice saying things like, don't say, I don't know, say something like, it's not coming back to me right now, or can we come back to it later, as a way to not feel like they were putting themselves down and saying, I don't know, I don't know, I don't know. For me, I felt that saying I don't know was the most efficient way to say next question, please, and move on. And if it was a critical question that I had to know the answer to, then the examiner would say, no, we're not moving on. I'm going to regrade the need. And I guess it just depends on how your mentality is on the day, and if you need a bit more TLC or if you're just focusing on efficiency and moving through the viva.
I think, the I don't know works if you are able to put other content into other questions. Does that make sense?
Yeah. If you say, I don't know, 5 questions in a row, then it's probably that you're struggling. But I expect, even when I've given some of these vivas to people who've gone on to get merits and prizes and things. And inevitably they say, I don't know, at some point along the way.
Correct. Which is what they want to push you towards. Yeah. Correct. And I think that's the really important thing, is that there are going to be questions that you have to, you have to know well. And then if you answer them well and you feel like you're being pushed, definitely, I think, be comfortable saying, I don't know, just so that, you can move on. And I think, that is definitely a point, because the examiners, what they want to do is they want to differentiate you. They want to push you as much as possible to see how you compare.
And sometimes I think when trainees who are preparing get given vivas from somebody who, they've written down their vivas like I had, if I gave this viva word for word to somebody and asked them all of these bonus push questions, for some people it would mean that the viva would take 7 or 8 minutes, and for some people it would be just punishing them with something that is beyond their level at the time that they did the practice viva. But the reality is that real examiners, I suspect that they've got 20 core questions and probably 20 bonus questions or even more, and they have such a breadth of ways that they can find ways to give you marks. And they're much better at kind of tailoring that to whoever is doing the viva.
Now, great. All right. Now, how were you feeling after the end of station 2 on the day?
Reasonably well. I think that was my first web chat viva, and there were no technical glitches for me, which was fortunate because it wasn't the same for everybody. I felt like I got off fairly unscathed with the starvation viva, because I think that, I think it's a challenging topic. It's an area where
metabolism is always hard. Yeah.
There's a lot of ambiguity in different textbooks, and they all say different time frames and things like that. And so I think there was kind of an example where I sometimes allowed my answers to be ambiguous. So what's happening at 48 hours? And I'd say, glycogen breakdown is probably finishing and gluconeogenesis is in the process of starting, as opposed to being too rigid in at this time, everything has stopped and everything has started. And a similar concept will come up in one of the later vivas as well, where in fact being vague can actually show a better degree of understanding of acknowledging that different textbooks say different things.
Well, I mean, the key thing that I got from the way that the questions were being asked was that, even at points of uncertainty, you know, when they sort of pushed you or sort of gave you like a leading question, you were able to actually get the right answer out. So, you know, for example, with regards to why don't normal people get ketoacidosis, you know, you had a really good description about the
they were definitely not
in the Krebs cycle.
At all.
Correct. And then they obviously going, well, no, that's not the it was that's obviously like probably the most correct answer, but they were going, well, you know, probably simpler than that. And then they went, oh, you know, was there a hormone? And you're like, yeah, sufficient insulin. And then boom, like you need, like looking at the question, I was going, yeah, you know, that's what they wanted. They gave you like another question and then you got it correct. So, you know, even though it wasn't perfect, they were able to sort of lead you and you were able to actually get the right answer from that. So that, I think that was very, very impressive.
I think the hemoglobin viva, I think that's probably a fairly common viva that I see people give. And I think everyone, if you get the opening step is what is hemoglobin, you need to have a nice 2 or 3 line definition. You can't just say the thing that carries oxygen and it's a protein. I think the coagulation and blood products viva, when I do this, the first part dumps a lot of people. And I think I've come across a couple of similar vivas from previous examiners where sometimes the opening stem and the first couple of questions, the majority of people might not get all the marks for. And so this was, you know, how do we do a PT test in the lab, which I only knew by a fortune of circumstances of a practice viva I'd had in the previous week. But even if you didn't know any of that, you can still comfortably pass the viva with all the discussions about warfarin and FFP and blood product storage. I remember hearing another one similarly, which was about, you know, side effects of antiseptics and comparing chlorhexidine and iodine. And a lot of people really struggle with that part. But then as soon as you say anaphylaxis to chlorhexidine, 80% of the viva is about anaphylaxis. And so even if you get really stumped at the first bit, that's not necessarily where all of the marks are. I don't know why they seem to do this, but it's not an uncommon style for how they design these vivas.
Great. All right.
Easy.
Let's go with station 3.
All right.
Okay. So station 3, the door stem is what is tramadol? Now, have you read and understood the question?
Yes, I have.
And what is tramadol?
So tramadol is an atypical opioid used for moderate to severe pain. It's an optical stereoisomer with isomer-specific actions as the mu agonist and serotonin noradrenaline reuptake inhibitor, and its metabolism is dependent on CYP2D6 polymorphism.
Now, we often say tramadol is a weak opioid. What does this mean?
So some texts describe tramadol as a partial agonist and others as a full agonist. I understand this as an equianalgesic dose, the opioid agonism is only the minority of its analgesic effect.
And how does tramadol's potency compare to morphines?
So we tend to dose tramadol at higher milligrams, so it would be less potent.
Good. Now, you mentioned its isomer-specific effects. Like, what are they?
So the positive isomer has mu, opioid, and serotonin reuptake inhibition actions, and the negative isomer has noradrenaline reuptake inhibition.
Now, tell me about its metabolism.
So first, it's metabolized by CYP2D6 to plus and minus O-desmethyltramadol. The plus isomer has an increase in opioid affinity, and it loses its serotonin actions, and the minus isomer retains its noradrenaline reuptake inhibition. And there's significant genetic polymorphism in the activity of CYP2D6.
Now, would you worry about someone who is an ultra-rapid metabolizer?
So these patients are at risk of having an increased opioid effect and therefore risk of narcosis or toxicity.
How about someone who is a poor metabolizer?
So these patients would have a reduction in analgesic effectiveness from less opioid activity and an increase in nausea from the serotonin activity.
Now, apart from CYP2D6, is there any other metabolic pathway for tramadol?
So the subsequent metabolism with CYP3A4, this goes to plus and minus N-desmethyltramadol.
And how about some drug interactions with tramadol?
So other serotonergics can contribute to serotonin syndrome, and you can develop hypertensive crises with monoamine oxidase inhibitors.
Now, Are there, or is there anything that impacts tramadol's metabolism?
So there are several drugs which can either induce or inhibit the CYP450 system.
And what are some inducers that you know about?
So these would be things like thiopentone, phenobarbital, St. John's wort, or smoking cigarette.
How about inhibitors?
So esomeprazole, fluconazole, antidepressants like fluoxetine, some antibiotics. That's all that comes to mind right now.
And now, any patients that you would be cautious about giving tramadol?
So the drug interactions, as I've mentioned, and probably those taking multiple other serotonergic drugs.
Well, how about the elderly? Why do we avoid tramadol in the elderly?
So I don't know off the top of my head. Perhaps a reduction in metabolism may lead to greater serotonergic side effects.
How about if I say, is tramadol renally cleared?
So both tramadol and its active and inactive metabolites are all renally cleared to a degree.
And would we use tramadol in someone with renal impairment?
We would tend to use a reduced dose.
Okay, good. Now let's move on. Now, can you define for me circulatory shock?
So shock is an inadequate delivery or utilization of oxygen, producing tissue hypoxia. The circulatory shock is broken down into hypovolemic, distributive, obstructive, and cardiogenic shock.
And if a patient loses 30% of their blood volume suddenly, what would happen to urine output?
So urine output would reduce due to both a reduction in MAP and decreased renal perfusion, as well as the actions of the sympathetic nervous system, renin-angiotensin-aldosterone system, and antidiuretic.
Now, where does ADH come from?
It's produced in the anterior hypothalamus, but it's secreted from the posterior pituitary.
And what factors influence ADH release?
So this is influenced by high and low pressure baroreceptors, as well as a range of other stresses, including physical and emotional.
Any other factors that you can think about?
Hyperosmolality.
Good. Now, tell me about the relative responsiveness to these triggers.
So osmolality is more sensitive, but has a lower gain of secretion, whereas the volume response is less sensitive, only activating after about a 10% loss of volume, but has a higher gain.
And what's the threshold for osmoreceptors?
As little as a 1 to 2% change.
And where are these osmoreceptors?
So these are the subcortical organ and the organovasculosum of the lamina terminalis, and these are paraventricular organs located near the hypothalamus.
And how about the baroreceptors? Where are they?
So the high pressure baroreceptors are in the carotid sinus and the aortic arch, and the low pressure baroreceptors are in the great veins and the right atrium.
Now, how does ADH contribute to a reduction in urine output?
So ADH results in an increase in aquaporin insertion, an increase in urea porins, as well as an increase in the activity of the sodium-potassium chloride pump in the loop of Henle.
Any other effects of ADH that you can think about that might be useful in hemorrhage?
So ADH also results in an increase in FBR and mean arterial pressure via V1 receptors.
Tell me about the activation of the renin-angiotensin system.
So in this case, the activation would be via the sympathetic nervous system, activating beta-1 receptors to release renin.
And tell me about angiotensin 2.
So angiotensin 2 has systemic vascular, renal vascular, and renal tubular effects, and results in an increase in systemic vascular resistance, as well as an increase in sodium and water reabsorption.
Tell me about renin. Where is it produced and what does it do?
So renin is produced by the granular cells at the afferent glomerular arteriole, and renin converts circulating angiotensinogen into angiotensin 1.
And how about aldosterone?
Its release is triggered by angiotensin 2 from the adrenal cortex, and it produces sodium and water reabsorption in the kidney, and also has some effects on acid-base and potassium balance.
Now, how about if you lost 10% of your blood volume? What would happen to urine output?
It would be relatively maintained.
All right, I'm going to hand over to Lahiru now.
Great. What types of muscle are there?
So there's fast twitch, slow twitch, and muscle spindles.
These are types of skeletal muscle. Any other types?
Smooth and cardiac.
How does cardiac muscle compare to skeletal muscle?
So cardiac muscle has spontaneous depolarization.
What about structurally?
So cardiac muscle has gap junctions, which allow the spreading of depolarization between adjacent myocytes, effectively creating a functional syncytium.
And Draw an SA node action potential.
Okay, so got my paper here. So just drawing my axes. Sorry about the red pen. So in the x-axis, we have time in milliseconds. The y-axis, we have membrane potential in millivolts. So here's our rough diagram. This is about -60. Threshold reached at -40 millivolts, goes up to about +20. And our phases are 0, 3, and 4.
Excellent. How long is this?
So it's approximately 250 milliseconds from the time threshold is reached until the end of phase 3.
What is happening in phase 4?
So during phase 4, the HCN funny current creates an influx of sodium and potassium ions, which outweighs some potassium efflux, which is by inwardly rectifying potassium channels. And this results in a slow depolarization until threshold is reached.
What happens at threshold?
So at threshold, there is the opening of both T-type and L-type calcium channels.
And why? So do these two types open at the same time?
So the T-types open first and briefly. The L-types open more slowly, but remain open for longer.
When does the potassium current start?
So this starts just shortly prior to the end of phase 0.
When does the calcium current stop?
It doesn't stop all at once, but the channels begin closing during the upslope of phase 0.
You've drawn phase 0, 3, and 4. Where are phase 1 and 2?
These are not demonstrated in pacemaker cells.
Okay, draw a ventricular action potential.
Okay, so axes are the same. So we've got time and membrane potential. Here's our rough diagram. So this is sort of -90, threshold reached at +70, getting to about, -70 up to about +20. And our phases here are 0, 1, 2, 3, and 4.
How long is this?
It's about 300 milliseconds.
So it's longer than the pacemaker cell?
That's correct.
You've drawn the threshold at -70 millivolts. You mentioned the gap junctions allow the current to spread. The pacemaker cell was at -60 millivolts. Why isn't this cell constantly depolarized?
This is because there's a different channel involved. So here it's a voltage-gated sodium channel rather than the L and T-type calcium channels.
Here we're going to move on to another topic. What is the structure of rock uranium?
So rock uranium is a monoquaternary amine.
Is rock uranium a big molecule?
It is small compared to most other non-polarizing microlights.
How does this compare with the structure of atracurium?
Atracurium is a bis quaternary amine, and it has an ester blockage.
How are they both able to produce neuromuscular blockade?
So the quaternary amine group is able to bind to the nicotinic acetylcholine receptors and block it.
How do they do this?
So they block the alpha subunit of both the pre- and post-synaptic nicotinic acetylcholine receptors.
What's the structure of succinthonium?
So there are 2 acetylcholine molecules which are joined by an acetyl linkage.
There are some other molecules called hexamethonium, which is ganglion blocker, and decamethonium, and muscle relaxant. Why does decamethonium cause paralysis, but not hexamethonium?
I have no idea.
How do we monitor paralysis?
So this can be done with quantitative neuromuscular monitoring or other less reliable clinical methods.
How is a train of 4 ratio generated?
So there are 4 supramaximal stimuli, 0.5 seconds apart, and the twitch height is observed, and then you compare the height of the 4th twitch to the first twitch.
What is a supramaximal stimulus?
So this is a stimulus which is greater than that required to cause depolarization of all motor neurons stimulated.
What sort of numbers do we see with the stimulus?
Often about 30 to 50 millivolts, depending on skin speed.
We don't measure current in volts.
Milliamps.
We also use double burst stimulus. Do you know what this is?
So this is 2 tetanic bursts of 3 stimuli, 1 second apart.
We also do a tetanic stimulation. What is this?
So this is a 5-second 50 hertz stimulus. There's then a pause, and then there is 1 stimulus each second and recording the number of twitches that occur. That would be a post-tetanic count as opposed to a tetanic stimulus.
Okay, good. Would we see tetanic facilitation with suxamethonium?
No.
What about phase 2 block?
Yes, we would at high doses.
Yeah, why is this?
So there's a few theories. So there's thought that there can be presynaptic action of sux at high doses. It can be postsynaptic desensitization, as well as an increase in sodium to potassium ACPH channel activity.
You mentioned clinical methods. Can you tell me about their sensitivity and specificity?
So sensitivity is the probability that a patient with a disease will show a positive test for their disease, and specificity is the probability that a patient without the disease will show a negative test.
But what do you think about their sensitivity and specificity and what that would be?
I'm not sure, but these tests are unreliable above a train-to-full ratio greater than 0.4.
Okay, let's end the Viva there. Yeah, nice one, Mason. His assistant had to leave us, but yeah, shall we go through how you felt about each of these Vivas? So...
I'm still here, but in the car.
Oh, got it.
Right.
Hey, Mason, so
wouldn't be the first Viva Stan's done with me in the car.
Nice. Brings memories, doesn't it? At 6, 7 o'clock in the morning.
Yeah, exactly right.
Hey, Mason, so with tramadol, anything to add there? Any parts that you felt good about? Would have answered different?
I think tramadol was it was something that I knew very well. It was, I think, by virtue of the way that my study group and I chose to kind of divvy up our topics, kind of everyone studied everything, but we divided things amongst sort of 4 or 5 of us, and each of us presented that to the rest of the groups when we met each week. And tramadol had happened to be one of my topics, so I knew its metabolism extremely well. And I think this was probably like, I've often said to people, I reckon there's a good chance that I passed this Viva in the first 30 seconds. That at the start, that I said, it's an atypical opioid. I could talk about the fact that it was an optical stereoisomer and that had different effects, and that its metabolism was about 2-IP2D6, which was effectively a roadmap to the remainder of the Viva. And, this was my doorstep. So I had, especially with the, 2 minutes of tech support time, I had about 4 minutes of thinking about tramadol to go in. So I had a fairly strong opening to this, and then a lot of it was just fleshing out details after that.
Yeah, excellent. Yeah, you go through some real detail about the isomer specific effects and everything, and yeah, no, really impressive.
Did you have a card beforehand, like just memorizing all these opening statements? Like, how did you go about creating such a strong opening answer for this?
So I didn't have a flashcard per se, but I had fairly good notes on this. I think, like tramadol, I always remembered it because it was, I think in the couple of years before I was doing my primary, there was a bunch of drama about tramadol and codeine in newly breastfeeding mothers floating around in some of ANSWER's documents because of 2D6 polymorphism. And for a while, it was not a good drug, and then it was actually a good drug because it was probably less harmful than using oxycodone. So I knew that the metabolism was relevant, particularly for sort of some Chinese, African, and Middle Eastern patients. I always remembered the isomers as the plus seemed positive, and for the positive were things like opioid and serotonin, because serotonin is a happy chemical. And I always remembered the negative as being negative for noradrenaline, and that was kind of just how I remembered those actions. And then with the first layer of metabolism, it goes down to the opioid get better and you lose all of the bad stuff, which was the nausea from the serotonin, whereas the noradrenaline largely unaffected. And I think the CYP450 inducers and inhibitors, they were just one of those things that you have a flashcard that you look at the day before and hope that you can remember as much of it as you can.
Yeah. Hey, I just want to touch on, you said you've had a study group. It was a very strong study group. I think one of the key things is, when you divvy up information, like how do you feel as if like you don't need to cover it yourself? Because there's obviously a vast amount of, information out there and you can get overwhelmed with how much it needs to be done. Like, how do you go about just, trusting your study group?
I guess you have to trust your study group for and if you don't, then maybe you're not in the right study group. And I don't think I can give useful advice on how to trust them. I think I was just very fortunate that we had a very reliable group that we all, took it as seriously as one another and we were all equally committed. I think that what we tried to do with how we divided up our study topics was, particularly if we studied our topics earlier in the week, we would, upload our notes early so that the rest of us could have a look at them. And we'd also almost keep like a reference list of, don't bother looking at these 2 textbooks. It's a waste of your time. If you're going to pick one, this is the textbook to look at. And so that kind of saved us from all just doubling up on efforts of looking at different texts. I kind of had the approach that if I went to study group and I already knew all of the content that my study group partners were going to teach me, then study group was a waste of time. But if I also went to study group and knew absolutely nothing about what they were going to teach me, then I would be too overwhelmed to be able to do it. So, I'd look at my topics in a reasonable amount of detail, and I'd probably spend, 30-40% of my week on my quarter of the content. And I spent the remainder doing a surface level coverage of what I was going to be, get more detail on from other people. And inevitably, there were a couple of questions that were just more conceptually challenging. And so those would be the ones that I'd really go into, okay, this is where I really want to be taught, and hopefully learn from somebody who's spent more time and got a better grip on this sort of difficulty.
Yeah.
And Mason, you had a real level of detail with the action potentials as well, and the channels, and which type opens first and second, and that's very impressive. How did you study that?
I think most of this detail was from I think it's Papano's that's the gold standard cardio textbook still.
The old one, yeah.
And I think I looked at it again in the last couple of days, and it has about 6 double columned pages just talking about the different action potentials. And the level of detail is excruciatingly big. So I think I ended up just committing to a moderate level of detail. And a big thing that I think helped my answers come across better here was that Papano is very big about it's not just like hard delineated phases. It's not that suddenly at phase 0, all of one channel turns off and all of the other channel turns on. And there's a lot of discussion about the channels open and close gradually, and it's just about the different balances between how many are open or closed at different times that produce the observed sort of measured membrane potential.
Amazing.
I must admit that the question about the length of the action potential between the SA node and the ventricular myocyte, it's something that is variable in different textbooks. Some they're exactly the same at 300 and 300, some they're 250 and 300. I'm not sure if they were kind of leading me to the question might have saying, it's longer than the pacemaker cell, saying that I got it incorrect, which is possible. But I think that for a lot of people, when they think there's the fast type and the slow type action potential, they think about how long or how fast the action potential is. Whereas my understanding for the fast type and slow type has always been that it's about the slope of phase 0 and how quickly the action potential can then propagate to the next cardiac myocyte along the chain.
You made some notes about drawing the threshold at -70. Can you comment on that?
So this is for the ventricular action potential?
Yeah, the very last question there. You're drawing a threshold at
that last bit. Yeah. I'm not sure 100% what that was about. I kind of get the point of, if gap junctions work so effectively and the membrane potential transmits from one cell to the next so rapidly, presumably at the border between a pacemaker cell and a regular ventricular myocyte, if one's already starting at 60 odd, how does that affect the threshold of 70 for the other? And I don't know the exact answer, except that I suspect there's a slight delay in that process, that it's not instantaneous, and that allows for some sort of channel resetting.
Yeah, okay. In terms of the muscle relaxant, again, sounds like it was all very stepwise. The answers weren't too bad. You had a lot of knowledge there, and also of neuromuscular monitoring as well. With the very last question, think about what do you think of their sensitivity and specificity would be? You got some notes on that. What do you reckon?
Yeah, so I'll admit I panicked when they asked me about sensitivity and specificity, and I think the panic in my brain just gave the definitions of the two, which wasn't what they wanted to do.
Which is fair to start with, though, just to get
your head. So I actually had to think about this quite a bit afterwards, because I think it's difficult to say, because when you talk about the clinical test of can you open your eyes, can you poke out your tongue, can you lift your arms up, defining which of that is a positive test and which is a negative test. Like, if you can open your eyes, is the test positive or is the test negative? I think becomes a bit jumbled. But I think my takeaway is probably that these things, you would say that they are highly specific in that if you cannot open your eyes, you cannot clench a fist, if you cannot lift your head off the pillow, then you are probably not adequately reversed. However, even if you can do those things, you can open your eyes, you can sit forward, you can reach for the tube, there is still the possibility you might be not above a train to full ratio greater than 90%. Hence why we need to have these tests available.
Yeah, I'd absolutely agree. All the clinical tests where we say lift head off pillow, poke tongue out, a strong grip, and good tidal volumes, those would all be positive and we'd still have a problem. And that's why we're doing train to full monitoring.
And I suspect this is another one of those vivas where, the first kind of 5 or 6 questions are all about muscle relaxant structure activity or structure function. And they asked me about hexamethonium and decamethonium, which I think I just laughed at them because I'd heard those words before, but had no idea what they were. And I think this was another one of those vivas where even if you got the first 6 questions incorrect, you could still pass the viva by talking in good detail about neuromuscular monitoring, because that's then what ended up the majority of the viva being. I certainly found that when I was doing revision and I was preparing for the vivas, you get the examiner's reports and it tells you the 100 or the 80 different viva stems. I'd often just go through with a highlighter and say, which ones would scare me? And every now and again, there'd be things like draw succinylmethonium, or, what is this molecule? And it would be bupivacaine, or it would be sevoflurane. And there's quite a lot of learning outcomes on structure function activity for volatile, for local anesthetics, for muscle relaxants, particularly for catecholamine, and how adrenaline is different from noradrenaline, is different from ephedrine. And I thought that those were areas where if I hadn't studied it and I got a viva, I thought I would fail the viva because it was something that you couldn't kind of waffle your way through. You had to know it or not. So I probably spent a reasonable amount of time studying those areas because I thought they were a weakness, which meant I was fairly well prepared for this when it came up.
Yeah, excellent. Hey, we've gone for quite a bit of time here, but is there anyone if anyone in the audience has any questions, could they put it into the chat? And that would enable us to, still keep anonymity, but, put any interesting questions out to the group. Yeah, thanks so much for your time, Mason. This is just how useful this was to go through, and also probably a bit scary for many of the trainees out there who are. So for the trainees who are thinking, oh my God, this is a ridiculous amount of knowledge and work and all the rest of it. Do you have any advice for them?
I think that can either be motivational or frightening. And, I think by virtue of the timing of when I first started studying for the part 1, I'd seen the video that you and Stan had done together of his viva recreation. And I think the first 2 weeks of teaching that I ever attended once I got my offer to start anaesthetics training, Stan ran the first one. And the second one was run by Dr. Ray Hugh, who also won the Renton a couple of years later. And so my kind of first 2 exposures to the primary exam were at a fairly high standard, which initially, scares the crap out of you to a bit. But it sets a standard that is achievable. But by no means do you need to know all of those minute bits of detail to pass. And I certainly have met some people along the way who they see things like this or things like Stan's video, and then they put a disproportionate amount of their time and energy into those really difficult bonus questions rather than having a good understanding of the core stuff. I feel like the classic example was Dan getting asked a question about one of the respiratory equation, and it was and there's always a correction factor at the end. Yeah. And they asked Dan, can you write out the correction factor? And there would be so many people I knew who would spend an hour or 2 hours or 3 hours trying to get their head around drawing the correction factor for, I don't know, it was the Bohr equation or something. But that's not where your time to value investment is, especially at times during your revision. Now, I'm all for, if you see something that you don't understand and you think is really interesting, spend a bit of time reading around it. And there are certainly some times, like at revision time, you can feel a bit bored when you're just looking at things that you already know. So sometimes learning something completely new can actually be a bit reinvigorating. But I think it's important to recognize when things are clearly bonus knowledge and when things are core knowledge, and find a way to hold yourself back from kind of going down the rabbit hole and wasting too much time.
Agree. I think that's a hard thing for all of us. Don't you agree, La? I mean, I think we feel like we need to know everything. And sometimes it comes to the detriment of actually knowing the things that we need to know well.
If you can't put the cannula in, you don't get to do the anesthetic, no matter how complicated, right? Or if you don't know the definition of something basic, you don't get to that bonus question. So yeah, it's such a tough balance to you're already probably quite bored and exhausted from doing all the usual stuff. It takes a lot of effort to just keep on the basics and just keep those going. Hey, there's something in the chat. This seems superhumanly fast. Does the way you are answering today reflect the speed you are answering in the actual viva?
So we talked a little bit about this beforehand, whether we try and recreate this to time or just to the script of what I actually remembered. This is probably a bit faster. It might be 20 or 30% faster than on average. Because I think so you have 20 minutes to do 4 stations, and I think we were probably doing them in about 14, 15 minutes on. So overall, it is a little bit faster. It does get slowed down a little bit by you having some reading time, and and between each of the 4 stations, there's like a brief pause. And I always encourage people that when you clearly finish one topic and you move on to the next, just have a glass of water or something that actually makes the examiners pause and finish. Because I think even in my first one, they asked me the opening question and they said, we might move on. And I said, I might have a glass of water. I might have a drink. And the examiner literally said, I think that's a great idea. And then let me finish. When I was composed, then ask the next question. So there would certainly be some questions where I would have spent more time thinking because I obviously didn't have a script. But I think my style of answering the primary viva questions was always, it's not about being polite. It's just about saying the answers as quickly as possible. So, some of my responses are fairly blunt. They might just be 1 word or 2-word answers. And I think that's fine. You don't have to say, well, thank you, examiner. That's true. The amount of people who say, that's a great question when you do practice vivas with them. It's like talking to a politician, all that does is take up time, but whereas you're going to get the most value out of just spitting out the knowledge. And if they want a more elaborate, detailed answer, then they will steer you in that direction.
Hey, Mason, I have a question. So when I was studying for my primary, I did not know action potential probably with this level of detail, as well as maybe the vaporizers. And that could just be a fact that it's got harder from time to time. When you're faced with a topic that isn't core anesthetic stuff, how did you get to the level of understanding that you have, especially when you don't necessarily have a tutor who would be an expert in that field? Like these are topics that anesthetists don't know very well at all. Like you can't just go up to a consultant and go, hey, can you explain to me L-type and T-type channels? Like it's just not going to work.
I think that deciding how much depth to study any topic to is one of the hardest parts of preparing for the primary exam. You read things like Nunn's Respiratory Physiology, where every chapter is written by a different person who's done 2 or 3 PhDs and spent 30 years researching the topic. And then you're studying that SAQ for a couple of hours at most. Or sometimes you've allocated yourself 45 minutes to learn about closing capacity or something. So particularly when you're early in your study preparation, it's really hard to know what's the benchmark, how much knowledge do I need to have. That's certainly one area where having a study group is helpful because you'll tend to all find a similar level of detail that you'll teach one another at. Certainly things like this podcast and other online resources give you an idea of what previous exams or previous things have required. I think the examiner's reports can be variable, and anyone who's read enough of the examiner's reports can see that they changed over the years, and sometimes they're really brief and sometimes they're really detailed and they put specifics in. And again, the examiners will sometimes make comments that seem like they're actually the bonus points that they wanted, not necessarily the core stuff. So there's not a perfect idea. I often found that there were general physiology textbooks or general pharmacology textbooks, things like Power and Cam or the other one, wasn't Chambers Physiology, is like they're a bit of a catch-all, cover everything. And then you've got the textbooks that are at the higher level of detail. So that's Nuns for respiratory, that's Papano for cardio, probably Vanders for renal. And so, if you read, some people say they read Vanders cover to cover, and that's probably impractical for most people. But sometimes getting most of your framework of understanding of a topic from one of those kind of catch-all bread and butter textbooks, and then having a quick glance through or read through something more detailed. I probably found I did that a lot in revision. I would have already studied a topic using the core text prior to the written exam. And then when I got around to doing viva practice, I spent probably a larger amount of time reading those more detailed textbooks, which it is a very different experience reading Nuns or reading Papano when you've been studying for 10 months compared to reading it when you've been studying for like a month or two, because you actually have got enough foundational knowledge that you don't feel like you're reading another language and you can actually sort of take in some of that information.
I was a big fan of going for the instant books as the very first thing, or a very good short answer question, and then the next level like Power and Cam, and then Nuns and Vanda, and then coming back to the summary or the instant.
Actually, I'd agree. I think I started my preparation on almost any topic by looking at the ketamine nightmares model answer for that short answer question, and that to me kind of just built the framework of what the topic was and what were the areas I needed to know. And then I would fill those gaps in with looking at the basic text or occasionally even more detailed one.
Yeah, that's good. I'm not sure. Don't think we have any more questions in the chat. And that's probably a lot of your time. Stan,
Yeah. Oh, no, one last question, Mason, before we go.
Yeah.
So you had 6 examiners on the day. Now,
that's correct. Yeah.
Did you find that there were differences, similarities? Like, did you find that you had favorites or ones that you felt, you didn't really get along with? Because I certainly had, one on the day that I thought I really liked, and then one was like really serious, and I thought, I don't know. What was your feeling about the 6?
Yeah, so mine was a little bit varied in that 4 of my examiners I only met via webcam. Only 2 of my 6 examiners I was actually face-to-face with. The 2 that I was face-to-face with probably were the more stern. And I felt like those were the vivas where I got interrupted a lot more. And they were also my first vivas. So I felt like I was, I wanted to get on a roll and I felt like I was being held back from doing so. I probably did have a few more smiles and head nods than I'd expected. When I said something that was obviously at a high level, people would smile or raise their eyes and go, yeah, that's, nice. And occasionally when they asked something ridiculous like hexamethonium and decamethonium, they'd almost look at their sheet of paper like, do I have to ask this? And then just laugh and say, that's okay, you can ask it, but I don't know the answer.
Actually, that's a good point. They're asking vivas that they haven't written. And, that's...
Yeah. That concept I found very unusual as well. So probably there were some that gave me a lot more emotional sort of facial sign feedback than others. But no one I felt was like outright hostile. Maybe had one who I thought was hostile in my part 2 exam, but all in all, I think if I end up with, one slightly grumpy examiner out of about, 15 over the course of my part 1 and part 2 exams, overall, that's a pretty good stretch.
That's a win.
Yeah. Generally friendly. And I've met now a handful of part 1 and part 2 examiners at study courses and things like that. And there are very few of them that are actually that gruff or grumpy. Most of them are pretty well-meaning, interested in you doing well.
You never felt like they were trying to trick you, with like, are you sure? Or, like the raising the eyebrows. Like you always felt like when they did that, they were trying to get you.
I can't think of any time where they said like, "Are you sure?" or made some obvious comment where I then didn't immediately realize I'd said something incorrect. I don't think they do that to psych you out. I think they do that when they see you're getting most things correct, and then you have a complete curveball, and they're giving you an opportunity to kind of steer yourself back on track.
Good.
Yeah, nice. No, thanks so much, Mason. Appreciate it. Hey.
Yeah, there's such an amazing use of this podcast, and also just your knowledge and your recall of this, like, so useful. As always, share with anyone who might be interested. Let's close up and yeah, thank you very much for joining us.
Awesome. Thanks very much, Lara. Thanks, Steph.
Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.